So good afternoon, everybody. Thank you for being here to join us. Actually, this is the last scientific seminar of this year for Karen Cross. And today you will see there's a little bit different setting. We actually have three panelists today. I will give a brief introduction of our lead speakers, Michael, and he will lead the way. So Michael has worked in NIH treatment research for 25 years. He's engaging communities affected by HIV in Seattle and across the U.S. in clinical trials towards the treatment and potential elimination of HIV, mostly through the ACTG network. He joined the Defeat HIV Martin Stanley collaborator as their community engagement project manager in 2013, focusing his efforts on cell and gene therapies for HIV cure. He is also proud to serve as the co-chair of the Community Advisory Board for the DARE Collaboratory. Michael has formerly worked as a high school English teacher, an actor, a director and producer of summer stock theater, and a baker of bread. He is a member of the steering committee for the Reunion Project, working to manifest events for HIV long-term survivors. Recently, he joined the Global Gene Therapy Initiative, an alliance of key stakeholders, including clinicians, scientists, engineers, advocates, and community members brought together to enable this access and implementation of gene therapies as curative medicine for present incurable disease in low and middle income countries. So we are really happy to have him here to lead this conversation about the challenges and opportunities of the use development, but mostly important is the use application of the cell therapy. And if you guys have any question, please use the Q&A icon at the bottom of the screen, and we'll try to visit those at the end of the talk. So with no further ado, Michael, please lead the lecture.
Great, thank you. Thank you. And I wanted to welcome everyone. I appreciate this chance to talk. And actually, when I was offered this chance to talk, the first thing I thought of was it's not as important to hear from me as it is to hear from other people. So I'm using this platform for a chance to feature two voices that I wanted to take the moment now and give them a chance to both introduce themselves before I get started with a little presentation that I have prepared. So Evelyn and Moses, I want to give you each a chance to let the world know who you are and where you're coming from. So why don't we start with Evelyn and then we'll go to Moses.
Hi, everyone. My name is Evelyn, and I come from Uganda, East Africa, just like my colleague Moses, he will introduce himself. When you talk about Michael and Moses, you're going to know their topic is going to be HIV. Now, when you talk about Evelyn, I come in on a platform of sickle cell. What brings us together with Michael, Moses, and I more is the Global Gene Therapy Initiative, which is an initiative or an agenda to raise awareness and demand for cures to be brought to where the burden is mostly. Not that you don't have the burden in the US, UK, anywhere, but I mean in the low resource centers like Uganda or in Africa, where the burden of both HIV and sickle cell is. I have a child who was born with sickle cell disease, Jeremy. And so my journey coming into sickle cell came on because of my son. His health started deteriorating and we were recommended to have bone marrow transplant done, which we did in 2021. And I was selected as his donor for stem cells. So I give birth to him twice. I am a patient and community advocate for sickle cell through and through. So you want to talk about sickle cell, you want to wake me at 3 a.m. at 4, ask me about sickle cell, and that is where I come in. Thank you.
Beautiful. Thank you, Evelyn. And Moses, why don't you tell us a little bit about yourself?
Thank you so much, ladies and gentlemen. I'm called Moses Supercharger. Living in Uganda, I'm a person openly and positively living with HIV since 1994. And I head a community-based organization called Joint Adherent Brothers and Sisters Against AIDS. And I'm also chairing the committee that is constructing the Artesium, the first global Artesium in Uganda. And I happen to be a musician, radio DJ, and I really love, my hobbies are music, making presentations to larger crowds, traveling, and of course, junk food. Thank you.
Thank you, Moses. So I appreciate both of you taking time out. I know it's late in Uganda, and I really appreciate you taking the time to give us your hour of talking. And hopefully we will be able to stir up some thoughts for people here. So I'm now going to share a little presentation that I've put together just to get us all thinking about what it means when we're talking about nothing about us without us. And so I'd like to share that first, and then I have some questions that I'm going to get started with Evelyn and Moses. But let me get this slide deck open first here. And can you all see this slide deck here?
Yes.
Great. So the title of this talk, we've borrowed it. But I wanted to actually start with this quote here by a woman that we all know, Elizabeth Merab, who passed away from sickle cell disease. And she has some really wise words that she shared before she left us. And she said that the only thing more difficult than hearing that you have a disease for which there are no cures is to hear that you have a disease for which cures are available, but they are not available to you. And that's really where we're starting from with this conversation. I want to keep her words in mind as we go here. So these next few slides I borrowed from a friend of ours named Jennifer Adair, who's a doctor at Fred Hutch. So as you probably know, if you have any inkling about gene therapy and gene therapy research, most of the trials are in the US. And in fact, the place that we don't see them are in what we call low and middle income countries. They've been left out of this research pipeline. And so it seems to be only certain places in this world where we get to do gene therapy research and get people involved in it. Unfortunately, these places are not where the burden of disease exists, especially when it comes to sickle cell disease and HIV. So they call them low and middle income countries, but I'd really like to use the other term that some of the advocates like to say, the majority world. And so we're talking about places where we can't do gene therapy research yet, but we need to. And so that's one of the things that we're hoping to inspire people with this conversation. So just some more little data, which has probably changed since these are a few years old now. There have been about 8 clinical trials to treat sickle cell disease between 2014 and 2022. In fact, we have 2 treatments right now for sickle cell. And we've had 36 clinical trials that are using some sort of gene or cell therapy to treat HIV infection, and they've been registered. But none of these are taking place yet in Africa. And that's something to consider when we're talking about trying to get people involved in this work. I also want to give you an idea of the human rights aspect of this. So this is a comment. Oops, let me go back. This is on automatic here. So REBSPA, oops, let me go back here. REBSPA is, oh, why is this doing this? REBSPA is the right for everyone to enjoy the benefits and the scientific progress and its applications. This is a part of the Universal Declaration of Human Rights. And so to consider that benefiting from scientific progress is a human right. And also then to get us to our title here. So we have this idea that nothing about us without us. So I came to this phrase through AIDS advocacy and AIDS empowerment, the Denver Principles, where it's basically telling us that people who are living with the disease should be involved in all the decisions that are being made around that disease, all the policies and all the regulation that comes about. They should have a say in this as much as anyone else. But if you look into this topic, Nothing About Us Without Us, you find out that this has a long history. So it didn't start with AIDS. It was existent long time before that. In fact, it actually started in Poland, they say, or in Central Europe. The idea was born, and it's been applied to many different groups now. So you have the disability movement has been taking this phrase on. And even today, we see other groups like sex workers or people who are interested in harm reduction for people who use drugs, using Nothing About Us Without Us. And even the World Health Organization is using it for things that are even not necessarily disease related, but just in terms of if you're coming up with policies for children or adolescents, you should have them participate in the making of the regulation and the policies you have. So this whole idea of Nothing About Us Without Us is where we want to start from. And so if we're talking about gene and cell therapies in Africa, getting them there, we should hear from people who are living in that country or in that continent and countries on that continent and hear from them. So I invited both Evelyn and Moses as two representatives from one country in Africa to talk about these things with us. And so I have a few questions that I wanted to get them talking, and then I want to open it up to everyone here. So I hope that you will have questions for our two panelists here as well, to give you as much of an education as we can possibly get you in 1 hour on what it is like in their country in terms of cell and gene therapy research. And so I wanted to start off, Evelyn and Moses. What made you become an advocate? And we kind of heard from you a little bit, Evelyn. Did you want to talk first?
I was thrown into advocacy by chance. The fact that my son was sick and there was little information out there, I just didn't want to bury myself into sorrow. Yes, it was sad, it was hard, especially without treatments, without drugs, without knowing what is going to happen tomorrow. I just wanted to help somebody. I didn't know that coming out to help, want to teach parents, it would grow large. I just didn't know how big it was, because I just thought, oh, I'm talking to the parents I'm with in the hospital. Because you're in the hospital, the room has about 50 beds, but 40 of those beds, each one has a child with sickle cell. And I'm like, but what is happening? Do they know what is happening? And then you talk to a parent and a parent tells you, no, I don't mind. That child is going to die. I'm just waiting for time. And I'm like, but what a sad way to live. So I decided to no. You shouldn't walk alone. I want to walk with you. It doesn't matter how far you are. It could be a phone call. It could be just a message to tell you, how are you doing? We had a number of parents losing their children. So, Michael, what is so surprising with sickle cell, and for all our listeners who may not know much about sickle cell, Moses will tell you, if Moses had come with pictures here to show you, he has a big number of young people living with HIV. But when you look at them, there is nothing on them that shows the disease is not labeled on them, just like the way you see Supercharger. He will walk around a handsome, sexy man everywhere. But with sickle cell, no, it is labeled on you. You look at somebody and you can identify them, and you look them out and see the yellow eyes, the embossing of the head, the delayed growth, the constant admissions. So like it just becomes a daily song. It doesn't matter whether you're taking folic acid, because folic acid is doing what? So it became something that you need to stand with somebody and just encourage them. If they lose a child, go with them for the burial. If they are admitted, find out, are you in the hospital? Can we help? Can we come and visit you? Can we sit together and learn, how do we take care of our children? How do we support each other? So that is how I was thrown into the advocacy, because there was need, there was gap. And I just wanted to be part of the team that is helping and strengthening other parents.
That's beautiful. Moses, what made you become an advocate?
Wow, thank you so much. It was around 1994 when I got to know that I had HIV in Uganda. and we didn't have a single tablet to treat HIV. So I was not on medication from 1994 up to 1996 when I was put on the first monotherapy, which was AZT drug. And around 1998, I was put on another drug which had to work with AZT. But these drugs were really very expensive. We didn't have the PEPFAR program like we do right now. And I used to buy medications like $500 every month. That is a lot of money if you're living in Africa. And in 1999, I developed HIV drug resistance and I nearly died. Because of stigma, the relatives decided that I had to be taken back to the village, because remember, I'm living in Kampala and my ancestral home is around 150 miles away from Kampala. So there was a discussion and I was hearing. I was very sick, but my ears were hearing very well. They were discussing that it would be very expensive to take my dead body back to my ancestral home, which is 150 miles. So they devised a plan to take me by public means and await my death and burial there in the village. So the next day I was put on a bus and I was taken to Kitaraganya. Spent 3 days, they were there every morning looking at me, waiting for me to die. I didn't die. Good enough, I had a sister who was abroad who came back and asked about me. They told her I was taken to the village. She had heard about a joint clinical research center, which had brought a new drug called protease inhibitor, Caletra at that time. So she picked me from the village immediately and took me to Joint Clinical Research Center. And I was put on this drug. And after like a month, I became really better. Now, I asked myself, what is this? The doctors, they told me this medication we are giving you, if it fails, there's no option. And they asked me what happened, what? So the problem, listen, the problem I had, that those medications before which I was buying, because I didn't have enough money, I could buy medication for a month and use them for 3 months. Take 2 days and skip 3 days. Take 2 days and skip 3 days, so that they can take me for like 3 months. That's why I developed resistance. And I only learned about that when I was being put on Caletra, a protease inhibitor, that you need to take medications every day. That's when I started asking myself that if Miss Supercharger, a person who went to school, somebody who works even on a radio station, if I didn't know the importance of taking medications correctly, how about the millions and millions of Africans living with HIV? So I said I need to start there and then reach out to the communities, tell them the importance of knowing their status, and if positive, put on medication. And if put on medication, take the medication as prescribed by a health worker. That's how I started my advocacy. Thank you.
Wow. That's a powerful story. Thank you for sharing that, both of you. I really appreciate you telling us that. I think these things are important to know because it's important for us to get an idea of what life is like for you in Uganda. So that was my next question. So for the people in Uganda, what is it like to live with sickle cell disease or HIV? How would you describe what is life like for them? Evelyn, I'll go back to you with sickle cell disease first.
So life with sickle cell disease in Uganda is still at that stage where information is still lacking. And one of the reasons why information is still low is because of resources, that there is no funds to give out the message, to disseminate the information. We are going back into the cycle of how it was with HIV when people would have myths that it is witchcraft, it is like this, until the resources and the partners came in to demystify the facts and say, hey, you get it like this. Now, sickle cell has been here longer than HIV. Sickle cell is not a new phenomenon. It is genetic. If I have a sickle gene and my partner has a sickle gene, none of us are sick. We have no symptoms. We have no challenges. Our parents are not sick. Our grandparents are not sick. But I have the sickle gene. My partner has the sickle gene, which we picked from one of our parents. Now it is me and my partner who can produce a child with sickle cell. Now, that information is less out there. So living with the disease is a very painful condition because it brings a lot of complications like stroke, anemia, severe infections, avascular necrosis, periapism that is on the side of the man, and so many other complications, including death. But when it comes to drug modifiers, now currently we have only one modifier, and that is hydroxyurea. It is a mild chemo, and it is what is being used to modify for those whom it works for. So living with sickle cell disease in Uganda or in Africa at large, it just puts you in the situation whereby you know very well there is not only cure out there, there is optimal care in the developed countries, yet we do not have the same here. So you live day by day not knowing when sickle cell is going to strike. One time my son told me he wants to write a book called My Prison, Sickle Cell. It imprisons you that your level is only pain and pain, because when this pain leaves today, where you're using morphine, you're using tramadol, where you're using pethidine, every line of painkiller, you know very well, less than a month or two, another pain is going to come. But now you don't know which one will take you, which one will leave you crippled, which one will leave you bedridden for years until you die. So that is what it is living with sickle cell in Uganda.
Thank you for that. Moses, how would you describe living with HIV in Uganda?
Wow. It's not a good situation. Right now, as we speak, Uganda has 1.5 million people tested with HIV, confirmed to be with HIV. But out of the 1.5 million people, 1.35 have accepted to start medication. So we have 150,000 Ugandans who have refused to start medication. And the 1.3 million people who are on medications face a lot of challenges, I'm telling you. The biggest challenge is stigma and discrimination we see every day. People being chased from jobs after knowing that you are HIV positive. Right now, I'm leading a group to sue 2 foreign companies that came to Uganda to do construction work, and then put up a mandatory HIV test for all the workers. So if you're positive, you don't get a job. If you are tested during your working and you find that you acquired HIV, you are dismissed right away. And that is against the constitution of Uganda. So this stigma and discrimination is really a big, big problem. Personally, in 2007, I was going to marry somebody I really loved so much, but I was rejected by the parents because I had come out openly telling the world that I'm HIV positive. People should watch out about these diseases. So I was trying to give lessons to people about this disease, and I ended up losing my relationship. Another problem is access. People walk like 30 miles to access this medication, to go to the clinics. People walk on foot. And sometimes the instabilities, you hear the wars breaking up in Western Uganda. People really find it hard to move to these clinics to access medication. We also have a problem of treatment failures. People are failing medication because of the poor treatment literacy. People are just put on medication without enough education about the importance of this medication and the danger you are likely to get when you don't take this medication correctly. Right now, we have 1 million people on first line, and then we have like 300,000 on second line, but we have like 3,500 people on third line intervention, and we don't have a fourth line. So it's not an easy thing. Young people born with HIV don't know whether their kidneys and livers will be able to take care of these toxic medications for the rest of their lives. So they are always yearning for an HIV cure and asking us, the people who are advocating for cure, when is it coming? Yeah, thank you.
Thank you, Moses. Yes. When is it coming? And so there's a great need for cures for both sickle cell disease and HIV. And at least with sickle cell, we know that there is a gene therapy cure that is available, but just not accessible to the people. So what do you think that the people in Uganda know about cell and gene therapy? What do you think they think about that? Do they even know about it? We'll start with Evelyn.
Okay. People who have access to internet, they have read about it, but access is limited to those who have smartphones or who have internet, because the videos move around, they throw them around back and forth. We've had a few meetings where we've engaged advocates, I and Moses. I know we've not yet gone deeper, but we've tried to share a few things with people, especially when Dr. Jennifer there was here. But would I say that people know much about gene and cell and gene therapy? I think the percentage may be lower than 2%. So I wouldn't want to say that they know so much about cell and gene therapy.
And Moses, how do you answer this? What do the people know about cell and gene therapy?
Just like Evelyn said, very few people know about this intervention. And like Evelyn said, we are trying to organize sessions periodically to see that we create advocates who can reach out to the general population to empower them about this intervention, although it's not in the country yet. But we are trying our best, our really best. Like on the 8th and 9th, we have organized 2 conferences in Uganda, basically for HIV cure, and part of it will be cell and gene therapy. Last year, Dr. Jane Adair, Dr. Mike McCune, Dr. Rimas Olentas, we are invited to Uganda, and they came and we interacted with hundreds of advocates and teach them about the cures, including cell and gene therapy. But 400 advocates out of the 45 million people we have in Uganda, it's still a small number, but we shall get there with all your support.
Yes, I like that. And so there's definitely a need for education as well as for research to be conducted in these areas where there's a predominance of both of these conditions for people. So then this is a question I wanted to ask both of you then. We want to talk about the meaningful involvement of people and those people who are living with sickle cell disease or HIV in research for cell and gene therapies. So what would the meaningful involvement of people look like in Uganda to you guys? And we'll start with you, Evelyn.
So the meaningful involvement of people living with sickle cell, first, let them be recognized that they are there. And in case you're doing any research, select advocates that you can train. Why? These advocates are people that the community listen to and believe in. You are not just going to come and find a group of parents, a group of people living with sickle cell, and you start telling them, oh, I'm doing this trial, I'm doing this research, come and be part. You don't even have the time to explain to them. Enroll, recruit advocates. These could be parents of children or people who live with sickle cell or people who are living with sickle cell themselves or anybody interested in this particular disease. Enroll them, give them a training to understand what kind of research you are doing, what are the protocols, who is benefiting, who is to be enrolled, and who is a candidate. Allow these advocates to go out there and talk to their people, talk to the community about what you're planning to do, how you are going to do it, and how they will benefit. Because it's not just a matter of someone saying, I have research, I'll be paying you this amount of money. No, we want people to appreciate, like the way Moses has mentioned, the drugs that he was put on. I think Moses has seen several trials from the, when you talk about 1998, you are looking at a cloud of HIV covering Uganda, whereby the statistics, the data is showing that by 2000 or 2010, almost everyone will have died. But these people were willing to participate in the trials because the advocates, the counselors were taught, and they can demystify all the theories, all the myths of the people who are willing to participate. So let the researchers, let the technical people bring us on board. Let them teach us and trust us to go out there and disseminate this beautiful work they are trying to do to our people so that they can embrace the new therapies and the research, and then we can achieve what we want.
Thank you, Evelyn. So Moses, what would the meaningful involvement of people living with HIV in this cell and gene therapy research look like in Uganda to you? Have we lost Moses?
Sorry. First and foremost, this would mean to me equity, regardless of religion, race, sexual orientation, so on and so forth. So when you bring an intervention, let everybody embrace it, regardless of those areas I've mentioned. Let every people enjoy the service or intervention. If it is research, don't discriminate and say Black people don't participate. This cure is for this intervention is for only people who are brown, etc. No. Create meaningful space for communities. When you have meetings and conferences, you have been to international conferences, and you see how we are treated. When it comes to our presentation, you will be given 10 minutes. Others will take 25 minutes. Lastly, also meaningful support. I mean, I will give you an example. I'm usually invited to attend meetings and make presentations. And they also invite professors and doctors. Then a doctor comes driving a very expensive Mercedes-Benz with fuel being paid by the funder of the research trial is working for. And then here I come walking on my foot like this. And they expect me to deliver as equal as this scientist or presenter who is getting a very huge salary, fat salary. So we are facing a lot of challenges because the work that we do is not funded. And somebody asked me one time, and I was really very disappointed. I told him I'm organizing a cure conference, and he said, you, a person who is not a doctor, organizing a cure conference? How? What? Why? These are things for the doctors. So we need meaningful involvement in everything that we do, meaningful support, meaningful space, and equity. Thank you.
Thank you. Yes, and I'd love to just reemphasize what you said. Funding it is the important part there. No matter what it looks like, you have to put the money behind it if you want to see it happen, or else it's not going to be able to grow. I really think that's important for everyone to hear that. My next question to you, so who are the other stakeholders? So we know that the people who live with these conditions, whether it's sickle cell or HIV, that they need to be involved in gene therapy research. But besides the people who could be the potential participants, who else do you think needs to be involved in gene therapy research in Uganda? Evelyn, we'll start with you again.
So besides the patients and the family, because when you're talking about the patients, it's a whole cascade whereby you need to involve the family. But other people that have to be involved are the clinicians themselves, whereby they need to know what is gene therapy, because it's really not good for a patient to come to their clinician or physician, and the patient is very, very much well knowledgeable. The parent is well knowledgeable about gene therapy. Now, I can give you an example. When it comes to bone marrow transplant, you're going to find many parents who have done a lot of research on bone marrow transplant. Perhaps they have engaged some of us who have gone through it. And then when they go to talk to their doctor, the doctor has no idea, has not taken much time to research on what is going on. So we need the clinical teams to be aware of where we are going and how far and what is on the table. Now, when it comes to Uganda, we have other tertiary influences. We are a religious community, whether you belong to a Christian fold or an Islamic fold. When you are a Christian, you listen to your spiritual head. That we cannot deny. You listen to your spiritual heads. Most of our people go to churches or go to mosque. Now, when you have the religious leaders as a tertiary beneficiary or influencers, and they are well conversant about the new treatments like gene therapy, whatever is going on, they can help the families accept to participate in these trials. We also have cultural influence. Most of us belong to kingdoms. And if I cannot talk to my spiritual head, but I have my cultural leaders, what are they saying about gene therapy? Are they saying it is bad? Are they saying it's against nature? No. But if they come up and make a statement and say, hey, our community, there is this treatment. If we have our prime minister for our kingdom speak about gene therapy, then everyone, if government of Uganda wanted to do immunization of a particular disease and they bring services in our kingdom where we come from, me and Moses, you may not get people. But if they involve the kingdom and the prime minister comes up and says one word that please go and take this, everyone will go. Everyone will go. And even if the president said anything, as long as our king has said something, we will all go. So we have those stakeholders, the religious leaders, the clinical teams, and our cultural leadership. I'll leave my colleague Moses to add on something.
Great. Moses, who do you think the other stakeholders are that need to be involved in it?
Number one, policymakers. We need to involve them. I'll give you an example. Some years back, somebody introduced a very nice trial that involved taking care of babies born with HIV early and giving them intervention and to see whether they'll be cured eventually. But remember, after that, you need to put these babies off their daily medications to see whether this medication has worked. And then there was one center that was really interested in this kind of work to participate, but it was directly under the government of Uganda. And the policy is that you test and treat. Somebody doesn't stop medication. So this site lost the opportunity to participate in this kind of research because the policy is that everybody should be on treatment. So, and if these policymakers knew about this kind of work right from the protocol development stage, probably they would have acted differently. So we need to involve policymakers right from the start of the research of any kind of intervention so that they know that something is coming. Like the funders, you need to involve them right from the start of any kind of intervention. Another stakeholder is the networks of people living with HIV in Uganda. They also need to be involved, like Nafofano, UNASO. They also need to be involved because they bring together all of us, the groups of people living with the HIV. We also need to take care of the caretakers. You are bringing cell and gene therapy. The work of the caretaker, of that person who is going to be put on a cell and gene therapy, is really very important. Now, if you didn't take care of that person to educate them about what they're likely to go through, they might think that it's just an intervention of 2 hours. You go there, they give it to you, then you go back and send the kid back to school. So they also need to be put another caretaker. I think the last one is the regulatory team of Uganda. Sometimes they take long to approve interventions because they need to be educated about this intervention. And yet for us, we want it urgently. So if we take them through about this cell and gene therapy early enough, probably the time of approval would really run smoothly. Thank you.
Thank you, Moses. Yeah, so I mean, I think it's just important for any of the scientists who may be listening to this to realize that there are more than just the people who live with the disease or the condition that you're trying to treat with your therapy. You have other stakeholders that have a vital role in the success of your trial and of your research, and to always be thinking larger than just the people who could be the potential trial participants. So my last question to you, before we open it up for other people's questions, is Evelyn and Moses, what do you think scientists could do to help you better engage people in Uganda around cell and gene therapy? And we'll start with Evelyn.
Okay, Michael.
Yes.
What I think scientists should do right now, first and foremost, whenever they make that proposal for any kind of research, they should always put their budget for the community involvement. Whenever they suggest any kind of research they want to do in any given country, let it be Uganda or whatever, the budget should also include community engagement. That's meaningful community engagement, not just community engagement, meaningful community engagement. That will really, really, really help. 2, let them periodically organize sessions where we are empowered. Let them visit their community advisory board and give them enough time so that they take them through the kind of research they are planning to do or the kind of research they are currently doing. That will also really, really, really help us. Scientists, you need to find a way of breaking down that jargonic language so that we understand the work that you are doing. The biggest challenge we are facing now, we enter your sessions and then you start talking those hard words and hard jargons. Really, most people go out not understanding a thing. So you need to find a way of breaking down the language into a community-friendly language. Thank you so much.
You're welcome. Evelyn, what do you think scientists can do to help you better engage people in Uganda around cell and gene therapy?
I concur with what Moses has said. Just like the way we said, nothing about us without us. You are starting something. You are starting a research, a project, a trial. Start with us. Do not bring us on board when you have done the groundwork and you've walked 10 miles. Bring us on board. Let's work with you. You start with us. We will learn the language. We will learn the jargon. Recognize the work and the work of the ICAB. Create an ICAB on your team and let these people be trained. They may not be medical workers. They may be laymen like me and Moses, but teach us, give us enough time. By the time you are ready to start your trials, we will know the words, we will know the slogans, we will be as close to you as need be.
Michael, can I jump in a little bit?
Sure, please.
To emphasize that question, I will give you an example. In the year 2000, when I was being put on the first protease inhibitor, that type of medication had to be kept in a refrigerator. And yet I didn't have a refrigerator. And the village where I was staying, the whole village didn't have electricity at all. Now, why did they bring that medication? Because in the first place, when they were developing the protocol and designing this kind of work, they never considered this medication to be brought to Africa. So first of all, they thought it will only be used in a place where there are electricity, and later on they realized that actually majority of the people with the problem are in sub-Saharan Africa. So we really struggled with Kaletra. Oh my God, because somebody never involved us. If he had involved us during protocol development, we would have advised him that that medication cannot work in Africa because majority of the people in Africa don't have electricity and the refrigerators. So it's really very important to involve us right from the start. Thank you.
Thank you. Thank you. And so now this is the part where I wanted to basically turn it over to other people's questions. And so what questions do you have for Moses and for Evelyn? Do we have any questions in the Q&A? Let us see.
Yes, we have some. Do you want to just go ahead and
Sure.
start that?
Sure, I can. So I'll read the questions to you, Evelyn and Moses, and you can answer. So the first question is from Jonita, and she says, they say, how do you deal with suspicion of tests being done on African people as the initial human testing grounds? Also, in the case of HIV and AIDS, would it be useful to further advocate youth in general regarding PrEP that way? The way the younger generation has potential to love freely with an added element of protection and prevention. So first of all, how do you deal with the suspicion of tests being done on African people as the initial human testing grounds? How do you deal with that?
I think that is what we were saying, that these are the myths that needs to be demystified. So because without proper knowledge out there, someone is going to throw there something, and then that's what they will pick up. If they are throwing their messages and we're not there to counter or to give the right one, someone is going to play something. That is what we've been saying. When you bring us on board, no one is going to throw such messages. We are going to be there to say, hey, no, that is not true. The truth is this. So now, without the truth being there, what is someone going to take?
And Moses?
Wow. On what Evelyn has said, I can't add anything. 100%.
All right. So we have another question here. Do you use community advisory boards in the community where the trials are being conducted? And if you do, how do you strike the balance between creating awareness on gene therapies and the fact that these treatment options are not widely available and that they're pricey? Moses, why don't we start with you?
Yes, we have community advisory boards in Uganda, especially at the research sites. And I'm sorry to say it's only one site, Joint Clinical Research Center, which has started interacting with this community advisory board on the issue of gene, cell, and gene therapy. So we've not had any other one doing that. But to answer your question, we are starting, and we are trying to request JCRC also to push in more support towards community involvement, which they are doing. And the last 3 sessions I've organized, conferences I've organized, they have fully supported this intervention because, like I told you, Michael, there's no way we can go and seek funding. And I'm really very grateful to JCRS and Caring Cross for supporting those last conferences. So advisory boards are there, the community ones, but we need them to be meaningful, like I said, yeah.
And Evelyn, do they have community advisory boards for sickle cell in Uganda?
I think we've not yet gotten there. I've not yet seen a community advisory board for sickle cell in Uganda. But I think that is where I want Moses to come in and guide and teach me how it has to be done. I think I will engage Moses and I will engage you, Michael. We have civil society organizations that are working in silos. So I think Moses needs to come in and help.
Yeah. Yeah, we
Because
don't have them in
now,
Uganda.
one of the things that I'm looking at is no longer going to be, oh, HIV. I think now we have to merge the two, really. We have to merge the two. The need is there so that we do not go back to zero. If I am to work on it as Evelyn, it means I'm going back to zero. If I respect Moses and Michael, you guys have been in the game for over 20 years. It will just be saying, Moses and Michael, come, guide. How do we go about it? Let me gather all the sickle cell organizations to sit in one room, and Moses and Michael come in and guide us so that we don't go back to the drawing board when you guys are already here.
No, I think that's wise. And I think that's one of the beautiful things is that we've learned lessons in HIV, especially as HIV advocates, and these can be shared with many groups. I mean, I don't think the idea of community advisory boards exists much outside of HIV and a few other select areas. So it's definitely one of the many things that I think we can teach each other. So the other part of that question, though, I would love to hear what you would have to say. So how do you guys strike a balance when you're talking to people about cell and gene therapies, that basically these treatment options are not yet widely available and they're very, very pricey? So how do you balance between letting people know about them, but then also let them know like they're not accessible to them? How do you handle that?
On my side, I choose my communities separately. I give you an example, like when it comes to bone marrow transplant, I'll not go up country 3-4 hours where people don't even have access to painkillers and then start talking about bone marrow transplant. There are places that I choose not to talk about gene therapy because it's like telling somebody there is sweet water in this at that high mountain, and yet everyone knows no one can reach there. So personally, I choose what to say according to where I am. For the communities that have access to this information, we are sharing with them this information as a hope. Because once people have hope, then keeping on holding is better than nothing.
Moses, how do you handle it?
For me, the group that I've usually interacted with is not young people, basically 16 and above. But I give them everything as it is. But before we do, like the sessions that we do, we emphasize that there is no cure for HIV right now, but there are efforts being done to make sure that we get a cure of HIV. We really say that like 100 times during our sessions. And whenever we bring these strategies and explain to them, they're really very hard and tricky questions that come from the community. Like, for instance, when you change my genes, won't I become a white man? When you do. So all these questions are being brought, and researchers, they take care of them really seriously. Yeah. But otherwise, we try to tell them everything that is happening so that they can grasp them slowly by slowly. You know, the subject of cure is really very complicated and the science is really too hard. Somebody needs to hear it over and over and over. If you decide to withdraw some jargons, then you are likely to face a problem in the future. Let them hear about them and then start digesting them slowly by slowly, month by month, year by year. Yeah, me, I was listening to this kind of science for like, sorry, 7 years. I couldn't pick a thing. But after like 7 years, I started getting something. Then eventually, I'm almost there. I'm almost getting to where Michael is.
Oh, I'm nowhere. Here's a great question. So, do you think that cell and gene therapy are a priority for the sub-Saharan African countries where the burden of sickle cell and HIV is so much higher and that the majority of the people are living in poverty? Do you think that cell and gene therapies are a priority?
On my side, in line of sickle cell, it is not a priority. The priority right now is newborn screening so that we can detect all the new cases. The second is premarital preconception screening so that we control the number of children being born with sickle cell. And third, most priority number is optimal care. So those who are living with sickle cell, even without a cure, let there be optimal care.
To me, it is indeed a priority. It is indeed a priority considering that we have close to 2,500 folks who have run out of, who failed first and second line, and they are taking third line. There's no fourth line. Now, if this medication fails, what is going to happen to these folks? There are 2,500 confirmed. Others are there struggling. We don't know about them. And leaving other numbers from countries like South Africa and what, if you put them together, in Africa, you are likely to have like 50,000 folks on the third line. Now, we need to bring cell and gene therapy.
Yeah, I'm not disagreeing that it is not a priority, but because we need the cure, but we want the patients of sickle cell to be alive, to be in good health before the cures come. So minus optimal care, you're going to bring the cures in 5-10 years, and there will be no one eligible for the treatment, for the cure.
Yeah, exactly. So, my response was geared towards people living with HIV only, because the younger persons, 99% of the people who are on third line are younger people. We expect them to live another 70 years. We want them to live another 70 years. They are on the last intervention. And considering the challenges of treatment in Africa, anytime they are going to fail. When they fail, we are going to let them just die like that. So that's why I prioritize cell and gene therapy to come to Uganda. Thank you.
And this is a question that's sort of related to what we've been talking about. Someone is asking, what about treatments that are not cell and gene therapy? Are there other promising fields with promising potential for cheaper alternatives to what we have seen with cell and gene therapies? Are there any that might be wiser for us to focus on?
I think the only cure so far that has been existent for sickle cell at the moment has been bone marrow stem cell transplants. And that is if you have a viable donor. But the cheapest you can get in India is about $40,000 US. That is if you've not had multiple admissions. So that is the only alternative we have. So far, besides bone marrow transplant, I don't know whether we have any other cure in line for sickle cell.
And we don't even have, you just said you don't even have hydroxyurea in any sort of organized
and hydroxyurea is not a cure, it's just a modifier.
Right, but a modifier.
Remember, we have only hydroxyurea. We had voxelotor from Pfizer, but it was withdrawn last month. Those are just modifiers. One of the things we've been campaigning for and asking, just like for HIV, where you have 2 or 3 drugs, each one targeting something different to give you optimal health, to give you comprehensive. In sickle cell, unfortunately, we do not have that package where you say, when you take this attacks this, when you take this, so you have a component that is helping you live. So we do not have. So if you are not faring well on hydroxyurea, chances are high you don't have any other modifier. But also the question, can you afford to buy hydroxyurea because you need to take it every day? But it is just a modifier. It is not a treatment.
Exactly. It's sort of like how antiretroviral therapy helps suppress HIV in the blood, but it's not a cure for HIV. They still have HIV, and as soon as they stop taking the pills, HIV comes back. I wanted to end with this one question here for us. Someone was asking if you had any examples of any collaborations between study staff and scientists and participants that you consider as a good model for future research. Can you think of any sort of examples of a good model between the scientists and the participants that you would consider a good model?
Maybe I'll leave Moses to handle that, being that he has participated in a number of things.
I'll give the work. I'll give an example of the work that is being done by ACTG. I mean, that is first class work, and I would sell that to the rest of the world. There's meaningful community involvement right from draft development, protocol development, into the trial. We are there. Michael, you've been there. You have seen them. We always there, and we are given time to contribute, and they listen to our concerns. Yes.
So with that, we are at time. And so I wanted to thank both of you for taking the time to talk to me and to talk to everybody. One person did put in the chat here that they thought this was a great talk and they felt it was important to hear your perspective. So I wanted to thank you both for taking the time at the late date and the late hour for you in Uganda to help us understand better what we could potentially do to involve people in cell and gene therapy. So I wanted to thank each of you, my friends. I really appreciate you taking the time, and I hope everyone who was listening today got something of value out of this. So Ying, I'll turn it over to you.
Yes, absolutely. Thank you so much, guys, to have this great talk. This is really eye-opening because as we scientists, we do everything in the bench in the lab, but this is really to hear something from your personal perspective at the patient side. It really, there's a lot of thinking definitely for us to do to how to make everything works better and how to make it work really to different locations, not just what we are at here, which we have so many different resources. That's very we're basically at a very different scenario as you guys are. So thank you again, thank you very much, and also thank you all the audience to participate and then to join the discussion. Hopefully, we really draw some attention to this really serious situation for the gene therapy, and hopefully everybody can keep the discussion even though the lectures ended, but the discussion should still keep going. And the final notice is we are having another education lecture on November 1st. We really hope that everyone can join us on that one. But by that being said, thank you again, everybody, and have a great weekend.
Yes, thank you, everyone. Take care. Bye, Moses. Bye,
Thank you.
Evelyn. Be well.
Bye, Moses. Bye, Evelyn. Bye, Mike.
Bye-bye.
Bye-bye,
Evelyn,
everyone.
Thank you so
you.
much. Yang, thanks you. Michael, thank you. Bye.
Bye-bye.